and I'm helping to do the PLTs with Sally. So the one we chose for today was the BLT, I was just about to say. I'm obviously a bit hungry. The B12. So for people who have done injections before but need to know a little bit more about the background of B12, because there is a little bit more to it than just the injections, which you'll see. So let me just get the PowerPoint up and I'll share our objectives. Is there any, actually, before we start, is there anybody here that's doing loads of B12s all the time?
Ellie, sorry, can we just consent for recording quickly?
Anybody got any objections to recording?
No.
Cool.
Thank you.
Is there anybody here who's doing loads and loads of B12 sort of non-stop, or no? Okay. So let's have a look at the PowerPoint. So I need to share my screen.
Hi, Gabby.
So as I'm sure you all know, when I'm doing the presentation, I cannot see anybody. So if anybody wants to just shout at me, then please do. If you've got any questions, we've got a bit of scenario time later on as well. So vitamin B12 deficiency, as we know, is the title.
I'll monitor the chat, Kelly. So if anyone needs to put anything in the chat, I'll have a look at that, or you can raise your hand and I'll see that if you want to ask a question.
Thank you. Okay, so we've got some learning objectives then. So basically, it's for us to describe what B12 deficiency is. What are the effects of a deficiency on the body? When would we test B12? Who might be at risk of deficiency? Why is an injection? Does everybody need an injection? And some dietary sources of B12. And for those of you who haven't seen it, this is the picture of it, this bright red stuff. It's kind of unmissable in these lovely little vials. Okay. So what is B12 deficiency? I mean, this isn't a trick question. Oh, I just let it pass. Got to shout out.
Vitamin deficiency.
Yeah, so what does deficiency mean?
Lack of.
Yeah. So if you've got insufficient stores of B12 in the body, and we find that on a blood test, and that lady's looking a bit tired. So vitamin B12, does anybody know what vitamin B12 does in the body? There's clues on the pictures.
Helps blood cells.
Yeah, helps us to create blood cells.
Our brain somehow as well, maybe, looking from the picture.
Yeah, exactly. It helps us to maintain a healthy nervous system.
Our heart.
Well, not specifically.
Yeah.
Yes, I can't remember what I was thinking when I put you saying there. I think I was thinking he's very healthy and fast, and he must have lots of energy. I don't know.
Someone's put aids metabolism on the chat.
What did they say? Sorry.
Aids metabolism.
Yeah. And the other one is DNA, helps us make RNA, or releases energy from food. So yeah, metabolism, perfect. And it's needed to make the building blocks of our cells. Cool. So it's pretty important. What are the symptoms of vitamin B12 deficiency? Oh,
Tiredness on the chat.
Yes, I'm getting the chat coming up on my iPad.
Oh, you can see it. Good.
Yeah, that's good, isn't it? Okay. Yeah, tiredness.
Yes.
That's right.
Vision issues.
Neurological issue. I think if it possibly visual issues. I'm not entirely. I think it would have to be really, really bad. Really bad. Tiredness is top one. Oh, yeah, the classic pins and needles. Okay, looks like Claudine is going to write something. Can't get away with anything on this because I can see if you're typing or not. Anything else while Claudine writes that? I don't want to put it in case it's what she says. You've got your mouth or ulcers or a sore tongue, so glossitis we call that. Nervous symptoms, yeah. Memory loss, so that's a big one. Changes in your cognitive ability, so even becoming confused. Low mood, muscle weakness, and even changes to someone's, I was supposed to say changes to the way someone walks, their gait, severe deficiency. Problems with vision, yes, okay. That's great. I mean, it's not great if you have it, but it's good that we've got that. Okay, so vitamin B12 deficiency can cause anemia, which is when we don't have enough hemoglobin carrying oxygen around our bodies. Do we know what some of the symptoms there of anemia are that could be caused by B12?
Tiredness.
Yeah, tiredness again. Fatigue. Not enough red blood cells. What are some other classic ones?
Hair loss.
Feeling faint. Extreme tiredness. The hair loss is usually like looking more like your thyroid, I think. But let's see if I put it on here. Very low energy levels. Shortness of breath. So that's quite an interesting one. Feeling faint, yeah, perfect. Mel said that. Headaches. Palpitations, pale skin, yeah. Pale skin is something that we would say more as a sign, as something that we notice on other people. Not sometimes people would say it, but it's not something that they feel themselves. But there you go, I'll put it there anyway. So when do we test for B12 deficiency in general practice? When do you guys actually take the blood test for B12?
When a doctor asks us after checking a patient's symptoms.
Yeah, that's
when they come of course.
Sorry, I missed that one.
When they've completed the B12 course.
Yeah, you may well do that because you want to check it's gone up. I mean, it will have gone sky high usually. But yeah, you're quite right. Any other times that you might do it routinely as part of your long-term conditions? Correct me if I'm wrong. I think it's on the dementia bloods, B12, for the memory when you do the memory screening.
I haven't actually done it in memory screening, sorry.
Okay. What do you do for the memory screening then? Just
we just do the basic ones, the kidneys, LFTs, cholesterol, diabetes, and the ALTs sometimes.
Okay.
Blood count.
So is that for people? Do you mean that's for people with dementia, or is that for people if you've done a questionnaire and you say you've done you're doing your part A and you've done your initial memory screen? Any issues with your memory? And the patient says, oh yeah. So you think, okay, I'll do my GP cog, and then you do usually you do dementia screening bloods as well, which has got a few different bits and bobs in.
I haven't added B12 to any of them.
Okay, so it'd be interesting to see well in your practices what the protocol is there. I'm just going to have a little look on my notepad because I've got for dementia bloods that I just keep written down for myself is TFT, full blood count, UNEs, HbA1c, LFT, and then B12 and folate as well. So because of symptoms, as you rightly said, and because the patient is anemic, so you don't always go straight off the bat doing B12, folate, iron. So sometimes you might think, oh, I've only just seen this patient to take blood and now I'm doing it again. Because some doctors will think, oh, if I check the B12 after, then I will be saving, it can be a bit of a cost-saving exercise rather than doing it. And then, so if they're anemic, you can then investigate the cause. Okay. Any questions about that side of things? Anybody doing anything different in practice or? Okay. So who is at risk of B12 deficiency?
Vegetarians, vegans, people with different diets.
Yeah, so vegans quite right. Vegetarians, I think, can get away with it, actually, just because it's often found in animal products. Elderly people, yeah. Crohn's disease, yeah, very good. People just sort of going on from the dietary business. It's not just people that have like a specific diet, say like I follow a vegan diet or I follow this diet, but some people just don't eat anything healthy at all. Some people eat really heavily processed foods, and so that can be a cause of B12 deficiency. So these ones we're calling your dietary causes of the deficiency. Yeah. But there are some other causes. Grace touched on it there in the chat about Crohn's. Can anybody think of patients that come for B12s, any particular types of patients with why they might need it?
Some patients who has part of their small bowels resection done in the past, they could.
Yeah, exactly. Some people who've had to have certain operations on the gut, they may have had some removed, because of cancer. They may have had to have part of their digestive tract removed. Who else might have an operation on their stomach? Some people. Yeah, bariatric surgery, isn't it? Yeah, exactly. Okay, that's very good. So non-dietary causes I've written down. So people with autoimmune conditions. So that means when the body is kind of I don't want to say attacking itself, but it kind of is. So these classic autoimmune conditions that we're talking about are like your type 1 diabetes, rheumatoid, for example. They're at increased risk of pernicious anemia, which we are going to go on to have a look at later. So, and other people that are on certain medications, like PPIs, which is like your lansoprazole, and omeprazole, which you probably see a lot of patients are on. They're your stomach protecting drugs, and they can cause vitamin B12 deficiency in the long run. And also, interestingly, metformin can. So loads of people that we know are on metformin, a lot of our patients. And then we also just touched there on the gut abnormalities like Crohn's, people who've had a partial removal of the stomach. Does anybody have any questions about these people that are at risk of B12 deficiency, or anybody got anything to add?
We had 2 patients at our surgery who were taking those, those helium gas or whatever it is, those gas. They were taking those, and then that led them to be B12 deficient.
Wow, that's really interesting.
Yeah, I don't know what the happy gas they were on that.
Laughing gas.
Yeah.
Okay, right. Wow. Okay, I've never heard of that one. They must have been taking a lot of
2 of our patients. Yeah, I think they were doing
they
it.
might live on my street, I think, because I'm always finding that. Always seeing those. Yeah. Okay. Pernicious anemia. How many people do you see that have, with B12 where you're coding pernicious anemia as a like roughly? Do you think if you even code that one? Have we even seen the pernicious anemia code? Actually, that's a good place to start. Not seeing it knocking about. Okay.
I haven't seen it.
No. Okay, that's fine. Do you tend to code, or do your nurses and other HCAs tend to code vitamin B12 deficiency, or are you not coding? Or, I mean, there's no right or wrong answer here. I'm just interested. It's possible that you haven't noticed because you're not there doing it. I just thought I'd. Okay. So with pernicious anemia, this is not really a case of the body you're not ingesting enough B12. What it means is the body just physically cannot absorb B12. So the body attacks and destroys the intrinsic factor, which is something that our body produces in our stomach to enable us to absorb B12. Yeah, not all of our B12 is absorbed that way. Some of it is absorbed much further down in the bowel, but this is the main way that we do it. So if we cannot absorb it through this route, we may well become deficient. Okay. And so this is an illustration of a stomach, and you can see there's these are little antibody things, and the B12 is binding to it. Okay, anybody got any questions about what this is and how it works? You don't need to be able to you don't need to go into reams and reams of detail when you're describing patients. Because their lives will probably start to gloss over, but this is sort of the kind of thing that you could describe to them. Would we feel comfortable sort of describing this to a patient if they had it? Yes, no, maybe?
Describing the diagram that you've put on there.
Describing what pernicious anemia is and
yeah, with those steps, I think I would be quite okay to.
Just to say,
say this is what it could be: exhaustion, short of breath, memory loss, sort of thing. Yeah.
Yeah, and the reason that people with pernicious anemia, I'm jumping ahead a bit, this is going to be later on, well, they need the injection because their body cannot absorb it through the stomach. Do you see where this, where the link is? Say I was B12 deficient. In some cases, I could take a lot of B12 orally, but I still might not be able to get up to speed, up to levels, because my stomach can't absorb it. Although I can absorb it further down in my gut, I might still not get enough. So that's why some people do need it through the injection, because with an injection, we know, don't we, it's just bypassing the stomach. And that's why we have to give it that way. Because I'm sure if the patients could get away with it, they wouldn't have the injection. So normally we say to the patients, oh, you're going to be on the B12 now, lifelong. Yeah, but I think especially now with coronavirus, it's really good for us to have a think, do we actually need to think patients injections? So consider just asking the GP and nurse when there's somebody's, if you don't know whether they're pernicious anemia or not, or whether they're just deficient in B12 for one reason or another, you could, and they've just ended up on long-term injections, just consider asking the GP or the nurse to order a celiac, intrinsic factor, full blood count if it's not been done recently, or B12, which you will see it being high, and if they're on injections, that's okay. They're not going to, they won't be overdosing or anything. It's just the way it tends to go. And then by doing that, you can see, is this dietary deficiency? Is it because they have celiac disease, which can cause the malabsorption of the B12? If they have intrinsic factor and that comes back as normal and the doctor signs that back as normal, that means that they don't have that pernicious anemia, which I just discussed. So you can check for intrinsic factor, like on this diagram. If you've got intrinsic factor and you haven't got the antibodies that attack it, then it's not pernicious anemia, so they might not need lifelong injections. So for those of you that have got loads and loads of patients on the books and they haven't had these investigations before, you might be able to look into it with the practice nurse and GPs as a little project, if you were interested to do that. And that way you can really get to the bottom of it, whether they need to take the injections. If it's a dietary deficiency, then they can take oral supplements. Yeah. If some people with a gut abnormality, or if they're taking some of those medications, they could try and take oral supplements and check, unless directed by a specialist. But obviously I wouldn't be expecting you to be taking all of this on. It's just an idea of what you might, think, maybe quality improvement projects or something that for your interest that you might want to understand, and see if there's any way that you could keep some of these people away. I say away, I mean that in a nice way, and protect yourself and others because of the COVID as well. So we don't need too many people coming in for injections if they don't even need them in the first place. But if they do have pernicious anemia, then they are going to need the injections. Yeah. Any questions about this? Anybody been filled with the burning interest in B12s now?
Can I just check something?
You
I would
can.
say the B12 injection is simply for patients that have pernicious anemia or celiac disease.
B12 injections are for people that cannot absorb it through their through their stomach. So if somebody's got celiac disease, if their celiac disease is not well controlled and is causing a lot of damage to the gut, as we know celiac disease can, and they might be malabsorbing. But if their celiac disease is okay, then they might get, they might not become vitamin B12 deficient in the first place.
Sometimes they'll have a letter from their specialist, somebody with Crohn's or celiacs or post-bariatric surgery might have a letter from their specialist recommending a particular course of B12. For example, some patients may be having it every 6 months as opposed to every 3 months by injection. So it's always worth checking for that as well, to see whether there's anything specific written if you know that they've got a bowel disorder.
Yeah. So it's not to say that they can't, but it may not be offered routinely. Some people will, their specialist might give it to them, and then they might end up moving over for one reason or another. Sometimes when people just have bariatric surgery, initially they're on a very specific diet with dietitian input, and you might find that is on that you're getting a letter from a dietitian, not just like a gastro person. So does that make sense?
I think sometimes it's patient choice as well, that some patients would prefer to have 6 monthly injections to having daily tablets, particularly those, for example, who are vegan and have got chronic low B12. But some people would choose the 6 monthly injections over daily tablets because they don't like taking tablets every day, whereas others would prefer to take tablets every day. So I think sometimes it's patient choice as well. Yeah,
that's right. And there is some information online about that, and if you've got queries about the regimen that people are on, you can always bring that to the GP or to the nurse and just say, why is this person, you could be saying, I'm interested, why is this person on so many weeks or months? They could perhaps go further, spread it out a bit longer, because most people that are on injections will have really high B12 levels. When it came to the pandemic and everybody was saying they wanted their B12 injections, the Hematology Society actually put something out saying you're going to be fine for ages with your liver supplies of B12. Don't worry. But obviously now time's dragging on and we're nearly a year on, and so we need to have a little think, especially as now our workloads have changed. Does that make sense to everybody? I'm not saying, go back into practice, tell everybody with B12 injections they don't need them anymore, but if they haven't had the full investigations, if it's not clear whether they're a dietary deficiency or a pernicious anemia, then you could certainly speak to your GP and nurse colleagues about that. So your standard B12 prescriptions. So normally it says on the BNF it says every 8 to 12 weeks. Some hematologist people will say, oh, if doing it any less than 12 weeks is just not necessary at all. Some patients will come in and they will be absolutely adamant that if they don't have it at 8 weeks, their wheels start to fall off and they're really lethargic and they get all sorts of symptoms. Yeah. And then the loading doses. Who's done loading doses? Anyone given them? Some doctors will do different numbers of loading doses, but essentially this is to boost your levels when they are low, and you'll feel like you're giving these patients an injection every other day, because you pretty much are, it will feel like. So Yeah, there you go.
And just to clarify, I think that there's been some chat previously about whether HCAs are allowed to give loading doses, and yes, you are. As long as you're trained to give B12 injections, you can give loading doses and you can give the 3 monthly doses. It doesn't make any difference.
Okay, that's interesting. Yeah, as long as you've got your prescription, obviously, you'll be working. Yeah.
And you might, so some doctors might prescribe as 5 loading doses and some as 6. It seems to be doctor's preference. But you just give what's prescribed. Although 6 is recommended.
I think I got that out of the BNF because I wasn't.
Yeah. So this is the correct. This is the correct one. So is everybody clear that they have the loading dose initially and then they go on to their 3 monthly?
Yeah. And if someone is a bit late for a B12 injection, you don't need to reload them. Okay. Standard B12 injection prescription. So yeah. Okay, so I did a little video just for those of you who haven't drawn it up before. I hope that it's useful. It's okay. It's not the best thing ever, but it's all right. It doesn't have any commentary either, so I've spared you from that. Okay. But can everybody see it actually? Can you see that screen? And I'm not playing it yet, but
Yeah, we can
Yeah.
see.
yeah.
Yeah.
Okay, go on then, let's watch it. Okay. Check the expiry date of your equipment and check the expiry date of the syringe, the vial. Preparing the equipment. Tapping the vial. Just make sure the solution is going a bit fast.
It does look very fast.
Bottom. Yeah, and then you snap the top of the vial. So for those of you that haven't done it, you snap the top of the vial, you just do an even pressure and you're snapping the neck of the vial. If you try and, if you do like an even pressure, it stops it from shattering. So you should only apply the pressure with the hand snapping the neck. So don't, it's very difficult for me to explain. If we were in real life, I'd be able to show you, but you don't need to push both sides. You just hold it with this hand and push with the other hand. Otherwise, you might end up smashing the bottom. I've never actually seen that happen, but I suppose in theory it could. So avoid pushing, pulling, or twisting when you're doing the vial, because that's going to cause all manner of problems. It kind of makes like a pop noise, yeah? And always apply the pressure away from the coloured dot. So there'll be a little dot usually on there if you've seen those. And if the glass vial does shatter, which on occasions it does, then you just need to discard it. This is something that you might practice a couple of times and you might feel like you did smash it or you spilt a bit or whatever. If that does happen, you know, it's not the end of the world, but you know, just discard it and start again. Okay. And then you pop the bin in the sharp, pop the top in the sharps bin. You draw it into a syringe with a blue needle, because a blue needle is fine enough that if there are any bits of glass in there, hopefully there won't be, but that's just good practice. Sally did say there's some nice filter needles out there. I've seen them in the past when I worked in the hospital, but I haven't seen them ever again. Does anybody have filter needles for drawing up?
No.
No. Yeah, I think they sound good. I think they're quite slow though, which puts some people off. So this is Michelle. You probably know Michelle drawing up a lovely B12 for us. Okay, what did she do? So it's best practice not to resheath the needle. Okay, but we didn't re-record because we thought this needle has never been in anybody. If Michelle did stab herself, she would obviously discard of it and do all of the appropriate business. But the best practice is not to resheathe needles. Okay. Expel the air and ensure the correct dose. So with the flu jabs, the pre-filled syringes, you might notice there's some air in there. When it comes to our injections that we draw up ourselves, we've got to make sure we get the air out. When they're creating them in the factory, those flu jabs, they know exactly how much air is in there, and they know it's not very much at all. But when we're doing it, we don't really know. So it's important that we get as much, we get all the air out. Yep. So there's Michelle checking the correct dose. And then she's got her fresh needle. She's put her other one in the sharps bin and she's ready to go. And then she'd prime the needle as well. Then she's got her vial there. Yeah. So then just before you give it, you just, make sure there's no air at the top from when you stopped it. Any questions about drawing up? Anybody feeling very confident, very apprehensive? What's the...
Ready to give it a go.
Yeah, that's it. That's all there is to it, isn't it? You just got to give it a bash. And it will make a lot more sense to you when you're doing it in practice rather than watching a video. But anyway, at least you don't have to look at my face the whole time. Okay.
And what you can do is you can get some of the little plastic things of saline and a needle and syringe and just have a practice if you've not drawn up anything in the past before, just to get the feeling of how it feels to draw up and to expel the air and get used to handling the needle, because it can take a little bit of time.
Yes, and you don't
do it over and over again. Then you don't have to waste a b12 vial while you're doing it. So just have a little practice.
And it's worth noting that you can turn the vial upside down. I think Michelle does do that in this video. And it's not going to fall out. Does she do it?
No.
No, she doesn't.
I was going to say, to see any limited patient to be signed off for B12 competency.
Sorry, I'm not sure I got the question.
It's a good question. What she asked us, is there any amount of patients she needs to be signed off for? Basically, it's to do with your competence, and I would get one person in practice, for example, the practice nurse that you're working with, to observe. Maybe you observe them a couple of times. You've probably already done that, but if you haven't, to observe them. And then they then observe you until they feel that you're competent, but also you feel that you're competent and you're confident to give. So there's no set number, and everyone will be different. Some people it might take a while because you won't be used at all to drawing up. Other people may have done it before and they may feel confident sooner. But the person you're working under needs to be confident that you are competent, and you need to feel like that yourself as well.
Yeah, and it's good to have somebody observing you for the duration of the appointment, so they can watch you from start to finish, explaining to the patient, consenting the patient for the injection, then drawing up, or you might prefer to draw up before you bring the patient in. I do, because I get nervous if they're watching me. I don't know why. I just do.
If you know what to give consent for the injection, do you have to pre-advise them about the vaccine, or whether they, I don't know, I'm not sure, I've never had a B12, but the area, would it be sore, or would they have temperature after the vaccine or anything?
Good question.
We've got a slide about that, but yeah, it might be sore. It's unlikely that they'll get a temperature. I mean, it won't. It's not a vaccine. It's a medication. It's a vitamin injection. So yeah, and fingers crossed. The chance of them ever having a reaction are very low.
All right.
Yeah. But certainly, when it comes to consenting, it's just a case of, I'm going to just do, just like you do for things where you don't even realise, or they know, a lot of the time they know what they're coming in for, but if they don't, you don't know how well it's been explained to them, what it's going to be like, when they need to come in for the next injection, all of that kind of thing. Yeah, that'll be good. Okay.
Painful arm is the main thing. Just any intramuscular injection, you're going to get pain in your arm.
Yeah.
There's obviously a chance of anaphylaxis with any medication, but it's very, very rare, and I've never seen it.
So the non-touch technique, so obviously wash your hands, you don't need to wear gloves. Best practice is to wipe the vial with a Steric and then let that dry. Draw up with a blue needle, we've already covered this. When you're drawing up, you obviously do not touch any of the key parts. So once you've opened that syringe, you can't touch the hub where the needle goes on the needle, you can't touch the where it goes in, the hub. If you don't put open needles and open syringes down on the kidney dish, even if you've wiped it down, because it's clean, but it's not aseptic. So if you can just suspend it or put it all together, and then that's a different story. But what you can't do is touch any of the key parts. Okay. There we go. Here we go. Just a bit. That's what ANTT stands for. A little reminder. Taking appropriate infection control precautions, touch non-key parts with confidence, never touch the key parts, and always wash your hands. Okay, so this is this is a bit of teaching you to suck eggs, but just as a reminder where the injection goes in. Anybody never given an intramuscular injection before? So if not, you need to go on that training before you give your B12s, just as a disclaimer. And for anybody that might be watching this back, take that as a yeah.
Just to say about the IM injection, Kelly, just because there's some articles that have come out since the COVID vaccination, which has said that there's been some people giving injections in the wrong places. So just to make sure you don't give it too high in the bony area, you see the top bit, because there've been some kind of shoulder injuries that have been caused by it being given too high. And obviously you don't want to give it too low because there's some nerves down there. So you just, if in doubt, if you haven't given one for a while, just get somebody to check your site with you so that you're happy with the position where you're giving it.
Yes, and
always expose the whole arm so you can see your area properly. Sometimes when they come in and they've got their clothes pulled up halfway over their arm, you can't actually visualise the whole area, and it's very hard to tell exactly where the deltoid is. So always make sure, even if it means taking off their layers, that you visualise the whole area. Yeah,
that's really good advice actually, because you see in these pictures on the BBC, you're thinking, oh my goodness, they're putting them really low down. I saw one the other day and I thought, yes, I thought about including it in here, but I thought, no, I won't. Positive mental attitude and keep. But
if in doubt, or if you feel you need a refresher, just go back to someone you're working with and say, can you just make sure that I'm giving it in the right place? Because the last thing you want to give it in the wrong place and end up with somebody having an injury. I'm sure that you've all given a million flu vaccines and you're experts.
Yeah, just feeling for that bony bit, then the 2 fingers, and then under there, and that's where you can do it. Yeah. Okay, so this is we touched a little bit on the possible adverse reactions. So soreness in the arm is the main one. This woman here, I was trying to convey that she might feel faint. I'm not sure if I got there. And then the adrenaline was there, but as Sally said, it's actually really rare. I mean, anaphylaxis is rare anyway, although it does happen, and we do have to know what to do. But it's very, very rare from B12. So yes, if they're a fainter, then you could have them on the couch. You know, the usual safety precautions that you would do.
And you should have all have done your anaphylaxis annually, and if you haven't, then you can do it on the e-learning for health online, and it's quite short to do.
That's good. So some dietary sources of B12. So this is where some vegan people can get into end up being deficient, because as you can see, it's mostly animal products and dairy, eggs. It's apparently, what was I reading? Some fancy shellfish is a very good source of B12, but it's not very realistic. So there's lots of different all cereals are reinforced with vitamin B12, and I feel like maybe some of our bread is our flour is as well. I'm not 100% sure on that. So there are, for vegans, you have dietary yeast, which has B12 in it, or take supplementation if they wish to go down that road. So sometimes you'll see when you're looking it up on the internet, B12 and folate are lumped together, and that's because they cause the same type of anemia, but they are actually different. Okay, so now we'll do some scenarios, if that's all right with everybody. So how many are we now?
Rezwana, you're going to Rezwana's going to split everybody into 4 groups. So we're just going to give you a number between 1 to 4, and then we're all going to discuss a different scenario for 10 minutes in our groups, and then we'll come back and feedback to each other. Rezwana, are you okay with that?
Yes, if you could give me like a few minutes just to
Yeah,
assign
of course. No problem. What we could do, Kelly, actually, while Rezwana's doing that, is we could just go to that slide about what they need to do before they can do it in practice. Does that work or not?
Yeah, there is.
Do you know what I mean?
I've just opened the PowerPoint and realised I'm not sharing my screen. There you go. So B12 training checklist is formal training and sign off in IM injections, which you guys have done. Understanding your PSD, so the prescription essentially, and knowing that who is having it, when who the patient is, when they're supposed to have it, how often, and what the actual dose is, and also how you do the B12 if the patient brings the B12 with them, or whether you have it in the practice and then you claim it back. That's all sort of the admin that you need to know. Then you need to be signed off by a competent nurse or a GP in practice after observation. And then do not give it until you've been signed off and you feel competent and confident, as Sally said earlier, which was very good advice.
Is everybody happy about the PSD side of things, that the prescription counts as a PSD? So it's not like the flu vaccine where you have to have a separate printed sheet with the patient's details on. But with the B12, because it's prescribed, the fact that it's been prescribed on the patient records and it's active acts as the PSD. So this wouldn't be the same for practice nurses. It would be the same for practice nurses actually in this case.
Yeah.
So it's the same for practice nurses and healthcare assistants.
Yeah. Because you need a registered nurse still needs their prescription, unless they're a prescriber.
Yeah.
The prescription in order to administer.
Does anyone have any questions about that? about how it will work in practice for them.
I think that was quite clear, Sally. On a question about the PSD, but now that you've mentioned the prescription works as a PSD, I think that's become a bit clear.
Yeah.
Thank you.
And we're going to talk about that a bit more in the scenarios as well.
Check with the GPs what they're happy with. Because normally on a PSD it says your name as well. So it is quite interesting that for this we don't have the person's name on it, but for flu jabs we do. And I'm not sure if that's just a loophole or what, Sally, what do you think?
I mean, I guess different practices may do things in different ways, so it is worth checking with your prescribers in your practice on how they want things to work for you, so that you're following local policy.
Yeah.
But the general opinion on injections like this is that the prescription counts as the PSD.
Yeah.
The other thing we haven't talked about is how, so some practices have a supply of B12 injections, and others the patients bring in their B12 injections. So you want to check what your practice policy is for that as well.
Yeah, I think I've just mentioned that.
Sorry guys, Sally, I'm ready to assign everyone. It's just one room has 2 people.
Okay.
Do you want the groups to be smaller, or is that okay to go ahead with 4 groups?
I think it's okay. Is it, Kelly?
Let's get rid of a group.
Okay.
Let's not do group 3.
Yeah. A group. We can just talk about the third scenario, can't we? Because that's not a very good one anyway. We could
the most.
Yeah, we could just do
interesting of them.
Group 1, 2, and 4 then, and we'll just have 3 groups. Does that work, Rizwana?
Yeah, that's fine.
Okay.
Okay, I'm going to put the scenarios into the chat now.
So just have a quick chat in your groups about what you think you would do, any ideas, and then we'll get you back together and feedback in 10 minutes. And it's just us.
I just got myself all confused.
Why?
Because I thought that everybody was leaving, and then I realised no, we've put them in the groups. Because it kept saying so and so is leaving, so and so is leaving. I was like, oh my god, they don't want to do this.
And they see the chat.
They should be, yeah. They should be able to.
Okay, good. Otherwise they'll just be there with no scenario. And do they know which group they're in?
Yes, they do. So it should say number 1 or number 3 or number 4.
Okay.
Oh, number 2. Number 1, 2, and 4.
Yeah, number 1, 2, and 4.
Okay, cool.
Well done, Kelly. That was really good.
I didn't think they were really interested.
I think they were.
Oh.
I think it's just hard to get feedback in that environment, that's all.
Yeah.
I think you did well.
Right, cheers.
And it's, you know, it's never going to be a really exciting topic, is it? But it's enough to get people up and going, giving B12s in practice, which is what the whole point is.
Yeah.
Sorry, quick question. Do you guys want to visit one of the rooms just to check if they're...
We're being recorded as well, by the way.
Oh, yeah. So I don't know if they can see any scenarios that you have given them.
They can't see the scenarios?
Yeah.
Okay.
I don't know if they can see it or not.
But this recording, we're not going to be in the final recording.
No, so this will... No. So so this will be cut out.
Okay.
Yeah. Because they don't need to see that.
Shall we, because we don't know whether they can see the scenarios, Kelly, so we need to go in. Shall each of us go into one group then?
Yeah. Okay, that's fine. I'll add Sally into 1.
Will I know which one I'm in?
Yeah, you're gonna automatically be put into that room. Now, I think. Yep.
I'm not. Oh, okay, 10 seconds it says.
I'm not getting that yet. Oh.
Hello. Hi, Jade. Oh, is everyone back? Or were you assigned to a room?
Yeah, but we didn't have some. Well, there was no one else in there.
Oh no. Do you want to go? Should I put you into a room now?
Yeah, please.
One second.
Okay.
Oh. What group am I in now?
You're back in the main room, Kelly.
Oh, okay. So people leave and then coming back.
Yeah, I don't think a few people, except I don't know if they went into the room, if they left the room. Mahima is back.
I don't know what happened.
Were you inside? Were you in a room?
I tried to message, but my message wasn't going. I wasn't connecting to anybody. I was just, I don't know, just blank.
That's strange. We're just in a black hole.
Yeah. It said I'm waiting to let me in.
Is Alison there? Because it's saying she's offline, but she's in the group. But I can see her.
Yeah, I can see that as well. I haven't heard anything from her.
It's confusing.
Me, I'm sorry, I'm so lost with this new chat.
So were you assigned into a room?
So it says join 3, and every time I join, I sign in, and then it brings me back to this chat.
Or maybe we are 3. Maybe we're 3. Okay. Let me just put something for you guys to have a chat about, and I will turn my sound off.
Do you want me to mute myself as well?
No, so Mahima, you and Shimu can do the scenario.
Me and who?
There's somebody
Shimu,
else in
is
this
it-
group.
Yeah, there's a person here, and Alison.
And Alison, but I think maybe we are the final group for the scenarios. So I'm happy to just turn off my sound so you can have a private conversation about the scenario, and then we'll come back.
Well, which group are we doing?
I'll just put it. Can you see the chat? Group 4. I'm not sure if you are group 4, but I'm going to. Let's hope for the best. Okay.
Can't see anything.
Oh no.
Can you see on the chat?
Meeting chat.
All I can see is everyone's name.
Right.
Can you see any messages coming up at the top?
No, the only message at the top is join 3, and it's giving me another link where to join. So every time I click on it, it takes me back into this chat actually. And then I join again. I don't know.
I don't know what to suggest other than. Or what if I just share my screen then for a minute, and then you can do group 4.
Is everybody else talking apart from
Yeah.
I think everybody else is in groups. Yeah. Can you see my screen now?
can see yours?
Yeah, you can? Okay, cool. All right, so I'll do group, let's just leave you then. For Rez, how long did you do the groups for?
It's whenever you guys are ready for everyone to come back. I can just close the room whenever.
Losing track of time a little bit. Okay, I'll come back in a few minutes just to give group 4 a chance to do some stuff. But I'm not listening in group 4. Okay.
What group are we, Kelly? Sorry.
Pardon?
What group am I doing?
So you.
So
I'm not
this
sure
is the
who's
group.
talking now because I can't see you because I've got the screen share up. But whoever's remaining in the group, that's not me or Rez, is group 4.
Oh, 4. Okay then.
Yeah, and you're just going to stay here, and I'm just going to mute my speakers so I can't hear you having a private conversation. Yeah, and Rez will do the same just for a bit. Okay.
That's fine.
Okay, lovely.
Sorry, who else is in my group? Hello? Sorry, I can't see anyone.
Hi, Mahima. You got abandoned. You're on mute still, sorry. Can you unmute yourself? Because I can't hear you. Can you hear me?
I can. I'm so sorry.
That's okay, that's okay. Oh, I'm sorry that you got abandoned.
Hello? Hello? Anyone? It's
Oh, okay. The scenario was that a patient comes for monthly B12, 3 monthly, sorry, B12. He follows a vegan diet. He asks you what kind of foods might help him to increase his B12 levels, and was wondering if there was any alternative to injections. What advice would you give?
So I would suggest that obviously because he's on a 3 monthly injection, I'd suggest he still gives that, and plus inform him that because he's a vegan, that's why he's got the deficiency. And I will also prompt him about the sources of vitamin, the B12, how he can uptake it in future if he doesn't obviously want the injection.
Yeah. So I mean that's good advice, because you don't want him to become deficient again. Do you think he really needs Do you think he needs B12 injections as a vegan?
As a vegan, because it's a dietary, he doesn't need it, I guess. He can obviously take over-the-counter supplements, but I was assuming he might have had the booster dosage, hence why he was having a 3 monthly one.
Yeah, so he will have had his loading doses at some point. You're right. He was wondering if there was any alternative to injections.
Kelly, everyone's coming back now.
Okay, so I'm sorry if some people had some problems with their breakout rooms. Was there some people that didn't get a scenario come up?
We were okay.
Yeah.
Was there a group that didn't get any scenario?
No, I think me and Kelly, I was just stuck by myself, and then Kelly joined.
Oh no, I'm so sorry.
Okay.
I'm sorry for any technical problems that people had with that. Did everyone manage to discuss a scenario or not?
Yes.
Sally, a few people left as well.
Some
Maybe
people
that's why
said that
Mahima was left.
some
by
people
herself.
they got stuck in a room by themselves. But that's fine. Let's just talk about the scenarios now, and then we'll see. We'll try to sort it out. So the first group 1, the scenario was a patient is booked. Kelly, are you able to put up the scenarios on the screen?
Yes, happy to do that.
A patient is booked with you for a B12 injection. They have brought the injection in and tell you that they have it every 3 months. You remember giving them the injection previously. You look on their EMIS record and there is no B12 injection prescribed on their medication list. What do you do? Someone from group 1 want to just feedback?
Well, we said that we wasn't going to give the patient the B12 injection without checking with the GP or first to find out whether they were really needed or not. And we said that we would also check the records to see if there was any previous prescriptions, or to see whether they had an appointment in the past, to find out what's happened, why it wasn't on EMIS. So that's what we said. We basically wouldn't give it until we knew exactly what was what.
Yeah.
Yeah.
So you wouldn't give. Obviously, if it's not prescribed, we can't give it, even if we remember that we've given it previously and the patient's come in with their medication. And I think you were saying as well, what else were you saying in your group? About looking into the reasons why.
Right, yeah, why it wasn't entered, why there was information missing, and why they needed it.
Yeah.
Yeah.
You're gone, Grace?
Yeah, we also mentioned about the sometimes if the patient has not been taking it, it goes into the past medication history. It's filed into the past medication, and it's not in the current medication list that we are looking at. So we may have to check with the doctor. Sometimes the doctor may have forgotten to put the prescription onto the system when they prescribed it to the patient. Yeah.
Yeah.
So I think we just have to ask the doctor to reinstate it again.
Yeah.
Sally said.
So there's different reasons you've brought up. I think, has it gone into past medications? Has it just kind of disappeared off because the patient hasn't picked it up for a while? In which case we still can't give until the doctor has reinstated it. And I think the group was saying that is there a reason why they don't need the B12 injection anymore? And we need to check that with the doctor, with the bloods. But the main take-home message is we can't give, even if we remember giving them previously, we can't give unless it's prescribed. Anything else to say from that group?
I'm not sure if it's just me, but I didn't hear all of that. But hopefully that's just me.
Is anyone else having connection problems, having difficulty hearing?
Nope, I can hear fine.
Okay.
Okay, good. Okay.
Okay, should we move on to group 2? Does anyone from group 2 want to feedback?
So said that we would try and console the patient, like try and comfort them first because they were a bit upset. And then we'll get help we'll go and take as much information as we can from them about their symptoms, because they're saying they've got pins and needles in their feet and not feeling well and everything. Try and get as much information as we can, and then we would go and seek help from a senior, like a GP or a nurse.
Yeah.
That's about it. I think Alice might want to say something else.
Anyone else want to say anything from that group?
We also discussed why she said she can't wait another week. So is it because she's going on holiday, or what? Why she can't wait another week, or is it because she's feeling so unwell? And obviously, yeah, highlight to the GP that she's having pins and needles, and obviously go to them with that information and what dose she's currently on and what regime, because yeah, might not be working for her.
Yeah, definitely. So I think that's good that you show compassion towards the patient. You haven't just told her to go away, come back in a week. Obviously, we have to be compassionate to patients' needs. If they're very distressed and they're getting symptoms, we need to bear that in mind. Is there any scenario where you would give it yourself? Would anyone give it? Would you be covered to give it a week early?
Not without a doctor's consent.
No.
Or a nurse's consent.
What about the doctor's busy and you ring the doctor and he says, oh yes, fine, just give early, it's fine, over the phone?
Nah, I wouldn't.
I still wouldn't give it.
I'd go and stand next to him.
Just wait after.
Yeah, so it needs to be documented there. Just a verbal consent wouldn't be enough in this scenario. So the doctor could give it, or any prescriber could give, if they were happy to give a week early and to document that themselves. But you wouldn't be covered to give a week early without a change in the prescription. But like you say, the patient's distressed.
Maybe.
Sorry?
Yeah, they could, in theory, they could write you a free note, not freehand, but as in the notes, they could write it so they don't have to adjust every prescription going forward. But as long as there's written authorization in the notes,
yeah.
You can get rid of it.
Is it going to be harmful to the patient to have it a week early?
Probably not, I think.
No. Generally vitamins, obviously we don't want to give it too often, but it's a vitamin, so the body takes what it needs and it excretes what it doesn't need. It's not going to be toxic for the patient to have it a week early. But we have to, you have to abide by the prescription. Oh, well done, Group 2. It sounds like you explored that quite well and you showed empathy towards the patient, which is really important. Should we move on to Group 4? Is there anyone from Group 4 that's happy to feedback? Did Group 4 get your scenario okay?
I think that was me.
Okay.
That was Mahima and me.
Okay. Did you have a chance to discuss it, or? Yeah.
Mahima, do you want to?
Yeah, I did discuss it with Kelly. I did say it might be that because he might have had his loading doses, so he's probably for his 3 monthly. I would give him the injection, but probably in future I would suggest to take B12 supplements, or give him information on sources of how to increase his vitamin levels, B12 levels.
Yeah. Yeah, so he's vegan, so Does he need to have injections necessarily?
And not necessarily, obviously, because it's a dietary. He doesn't need injection. Yeah. So it depends if it's had a loading dose. If it hasn't, then yeah, I wouldn't probably give it and just advise him on what to eat and give him a leaflet just to obviously for him to have feed.
Yeah. I mean, it's a discussion to have with one of the clinicians. Obviously, we wouldn't not give it, but it would be a situation where the clinicians could review him and see whether he was appropriate for tablets or not. And sometimes they might be able to reduce the amount of injections he has. So some patients might go on to 6 monthly injections if it's just dietary. But certainly,
he needs investigation if he has been low in vitamin B12. Just because he's a vegan, I think you did mention this in the group, Mahima. You said about the blood tests. Because just because you're a vegan doesn't mean you don't have pernicious anemia. So if you turn out to be a vegan with pernicious anemia, then taking as much, in trying to increase your dietary sources of B12 might not necessarily work for you. So that's where those blood tests come into it.
Yeah, well done. Sorry, you were on your own, Mahima.
Yeah. And then I was like, okay, I'll go now. And then
I was saying hello, and no one was responding. I was like, oh my gosh.
I'm sorry. And poor Jade was in a black hole somewhere, but we found you all in the end, hopefully. We're going to have a break now. We're going to come back and do the HCA forum. So anyone who's an HCA who wants to stay on for that, you're welcome after a break. I was just going to, I've got some information I was just going to share about the Nurse Associate Programme, just because some people had asked about that previously. And we've just got some information on the future sessions that we've got planned. And then just a chat about anything you want to chat about or any cases you want to bring. Obviously, open doors nurses, you won't need to stay for that. So you're free to leave.
What's the HCA forms about?
Sorry, Kelly, I can't hear you.
Sally, what were the HCA forms about?
I didn't hear, sorry, just say that one more time.
You mentioned about the forms for the HCA, whether we wanted to, I don't know, said something. I couldn't understand.
Oh, sorry. We have a forum now for HCAs. So it's just an opportunity to chat about anything you want to chat about, bring any cases. And I was just going to discuss, because some people asked me at the last session about assistant practitioner training. So I've just got a little bit of information about the Nurse Associate Programme, if anyone's interested in it. And we've just got some information about future sessions we're going to be running. So
do I? Because obviously I'm very new. Don't know what to use. Stay.
Sorry.
Would you suggest that I stay?
We suggest everybody would, stay. If you've got time, if you haven't got to rush back to clinics.
Sally, would you like me to stop recording now?
Yes, please. So we're going to have a tea break. How long do people want? 10 minutes?